If it's too loud, just buzz, tell me, okay? I appreciate it. Thank you. I'm glad you all just got a break because this is going to be awesome. Everybody got coffee? We're talking about nerves. Everybody's super excited about it. All right, cool. Disclosures. I took this when we were here at the Alamo Bowl. That's the Alamo, if you didn't know. It's from my hotel room. I don't get paid to do anything other than the jobs I get paid to do. So if somebody's looking for somebody to pay extra money to, call me. I'm happy to take it. So for you guys today, what we want to talk about, the neuroanatomy. We want to talk about the neurological examination of the upper extremity. I was told I had 45 minutes to do this. I had laughed and said that's not possible. But the good news is you guys are all pretty familiar with 95% of my talk. A lot of this is going to be a review. At least I hope it is. If it's not, discreetly raise your hand and I'll slow down, okay? So my main goal today is to really get into that differential diagnosis of when somebody has something neurologically wrong with their upper extremity, how do we kind of tease that out? Where are we looking for these types of things? We're going to talk about some nerve entrapments that have probably seen you, but you may not have seen them. Recognize some neurological tests that can help you differentiate some of those things. And then talk about some neurological conditions that can cause symptoms in the upper extremity that may not be nerve specific. And then those exam findings that are pathologic, those things that scare us a little bit, that make us kind of perk up our antenna and refer a little faster than normal. So we're going to do a lot of talking about anatomy, okay? So buckle up, get ready. Anybody watch Grey's Anatomy? Yeah, I don't. I'm a doctor. The medicine's terrible. I highly suggest you pay no attention to the medical stuff. Only listen to the drama part. The call rooms are not that active in my hospital. All right, so let's get into the anatomy. We're going to talk about some cranial nerves. There is one cranial nerve that really affects the upper extremity more than most, and that's the spinal accessory nerve, that cranial nerve number 11. It comes out through that jugular foramen there, you can see as it exits, and comes down and innervates that trapezius, the upper trapezius, and sternocleidomastoid. Nothing earth-shattering here. During my physical exam, I usually make sure they can shrug their shoulders and turn their head side to side. The thing here to remember is that the sternocleidomastoid is kind of a contralateral muscle. So the left muscle turns the head to the right because of the way it attaches. It attaches at the sternum and the mastoid, and it pulls and turns the head away from the muscle. I notice a lot of my sports medicine fellows get that confused, so just wanted to point that out. The cervical spine itself is huge in the upper extremity because that's where everything comes from, okay? So when we look at this, we have to rule out something severe in the cervical spine. And if it's chronic, we have to rule out something like bulging discs or facet disease, arthritis, especially in older patients. And most of your younger athletes, it's not going to be that arthritis-y type picture. It's going to be more of a bulging disc or something acute. This brings up my first point. History is everything. History, 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 all right? So if somebody comes into you and says, I got neck pain when X happened, X is important. Pay attention to that. Find out as much information as you can because that's really gonna point your laser in the right direction when you're trying to figure out what's causing this problem. If somebody comes to you and says, I've had neck pain for 6 months, you should probably roll your eyes and be like, why am I finding out about this today? And then you should start figuring out what X was 6 months ago. And for middle school kids and high school kids, and especially college kids, finding that out can be tricky. A lot of times they didn't pay attention to it back then because they thought it would just go away. So really pay attention to your history. So for cervical stuff, especially disc stuff, this is more that chronic thing. You know, I turn my head a certain way and I get this shock down my arm, or I get a tingling in my fingertips. Pay attention to all those types of things, all right? The cervical nerve roots can definitely get pinched. By far and away, the most common thing is a cervical disc, all right? Now, in some people, you get those folks with facets. So the facets are those articulating joints in the spine that kind of stop rotation and stop hyperextension and hyperflexion, especially in the cervical spine. And those facets have joint capsules around them too. And those joint capsules can swell. So sometimes you can get nerve root impingement from that. One of the ways to do it is either put traction on that area and see if it reproduces their symptoms, or even to compress it. So there's some debate here. Netters is calling Sperling's this maneuver here. You'll find some people that do Sperling's where they tilt their head back, tilt it to the side, and then do an axial compression. And if that reproduces the symptoms, they'll call that a positive Sperling's as well. So Sperling's maneuver here can help you. Range of motion in the cervical spine is huge. Make sure when you tell them to look up, they're not just using their eyes, because that's the number one thing that, 42 IQ says. I'm just going to look straight up. Make sure they lean their head all the way back. They look down at the floor. They look left and right, so that you're making sure they have actual full range of motion and they're not compensating with either their thoracic spine or their upper extremities. Sometimes you can get actual, the easy stuff for you guys is hit in football, arms and legs went numb. That's easy, right? Collar, board, hospital. You don't have to make any decisions. I'm talking about things that they come into the athletic training room a couple of days later, or something's been bothering them for a while. This isn't an acute disaster talk, okay? Dermatomes, I will tell you this. Most of you are probably more familiar with the color dermatome map here that has the cervical, thoracic, and lumbar spine, sacral spine. I like to use the Asia dermatome map. It's the American Spine Injury Association, because especially in the upper extremity, dermatomes can be notoriously unpredictable. There's a lot of variation with whether C4 is involved in nerves, C5, T1, C8. So I like to use this map here, and this map will be in your handouts. It's in your Google Docs. It's a freely available one. If you just Google Asia spine injury, it's the first thing that pops up under images. But every little dot here represents where you should palpate to find out that dermatome, whether it's intact or not. That way you're not running your hand all the way up the arm trying to figure out exactly where it is. So say let's talk about C5 or C6. If we're talking about C6, if you touch right here over the top of the thumb, if they feel that, it's intact. You don't have to keep working your way up. If it's intact distally, it's intact proximally. Same for myotomes. Myotomes here can be very variable. Very variable is not a great way to phrase it. But they're a little bit more predictable. The motor function of the upper extremity is a little bit more predictable. But again, I go back to Asia. It talks here in the upper extremity. So C5 is that elbow flexion. C6 is that wrist extension. C7 is that push off or elbow extension. C8 are those finger flexors. So if they can flex that DIP of the finger like that. And then T1 is if they can open their hand and abduct that little finger and do it against resistance. So that's more T1. Play around with it, any dancers in here, you can make up a dance, 5, 6, 7, 8, do whatever you want to do. But if you can remember those movements, if those are grossly intact, those cervical nerve roots are intact. That doesn't necessarily mean those nerves that innervate those muscles are perfect, but it means those nerve roots are there, okay? Speaking of nerve roots, remember in the cervical spine, we have 7 vertebrae, but 8 nerve roots, and that's because of the way those nerves exit the foramina. So in the cervical spine, they exit over the top of the pedicle until you get to C7, and then they start to exit underneath, which is why they had to add that extra one. Whoever started naming them was like, okay, cool, C1, C2, C3, C4, C5, C6, C7. Dang it. So remember, there's a C8. Don't forget C8. Also, pay attention to reflexes. Reflexes are huge, and this is something in the upper extremity that not a lot of people are confident with. They don't feel comfortable doing upper extremity reflexes. They're not particularly hard to do. Any reflex is the same. You put something over the top of the thing you're testing and you hit it and see what happens. You just got to make sure that they're relaxed, okay? So remember, C5 is really that biceps tendon reflex that you put your finger here, you smack it, and they flex their arm. C6 is that brachioradialis, so a little bit more distal, a little bit more radial. And then C7 is that tricep. So the hard one to test is the tricep, because you got to get them to relax their arm in this position. But it can definitely be done. All right, so those nerves that come directly from the cervical roots, there aren't a lot that we deal with that we really pay a lot of attention to in sports medicine, but there are a couple. The supraclavicular nerve is really a sensory-only nerve, and you got to pay attention to that sensory versus sensory and motor. But that supraclavicular nerve kind of gives you that sensation over the top of your shoulder. And that comes directly off the nerve roots. It doesn't run out of the brachial plexus, but it comes directly from the nerve roots, okay? So if you're getting a sensory deficit here and you've lost an entire myotome, you should be looking way up proximal. Something proximal has happened, all right? And that's kind of how you start to tease it. The more distal something is going on, the more distal the lesion is. So if you're isolated down here and it's not happening up here, start thinking things are happening more distal. If it's happening through the whole arm, you should be paying attention all the way up at the top, okay? And then I always throw the phrenic nerve in here because we don't think about it a lot. It's not really a sports medicine nerve because it's not one of those that we work out a lot, but we really probably should be paying more attention to the diaphragm. I'm not a huge fan of rhymes because in medicine everybody thinks because it rhymes it's true. It's not a true statement, but we do come up with a lot of them. But C3, 4, and 5, keep the diaphragm alive, is really a pretty decent one if you're trying to remember the nerve roots for the diaphragm and the phrenic nerve. It's more important than we give it credit for. We do have a lot of diaphragmatic dysfunction. So we're going to talk about the brachial plexus. Yay. All those excited faces. How many of you had to memorize it and draw it? 1,000 times? 10,000 times? So everybody's, oh good. Here we go. Why did I come to this talk? He's going to talk about the brachial plexus. What if he calls on me and asks me which one it is? Hey, you in the back. You're going to be okay. I'm not going to call on anybody. Everything's going to be fine. But we are going to talk about the brachial plexus. All right? The brachial plexus is part of the peripheral nervous system. It's not central nervous system. It's the peripheral nervous system. So you need to pay attention to that. That's important to tell the difference between a central lesion and a peripheral lesion, okay? And then you get the old netters talk about, oh my God, this is super complicated. I'm going to try to break it down for you a little bit. It's divided up into those roots. Again, we talked about those roots. And then you got the trunks. And then you have the divisions. And then you have the cords. And you have the branches. So does everybody know the mnemonic for how to remember this? What the order they go in, roots, trunks, all that kind of stuff. I always learned it as Randy Travis drinks cold beer. If you're not a country music fan, find somebody who has the same initials that sings something differently. But Randy Travis drinks cold beer. I will tell you this, you don't talk about the divisions very much because not a lot comes out of the divisions. The divisions are really just the merging of the cords and the trunks, or from the trunks to the cords and those crossovers. So we won't talk too much about division. There is definitely some variability person to person. Some people get a lot of C4 contribution coming in down here. Some people get very little T1. Some people get some T2 contribution. So it's not 100%, but as a general rule, this is pretty predictable. All right. So we're going to start with those that just arrive directly from the brachial plexus, from the roots, those more proximal lesions. That dorsal scapular nerve is really one of those that helps with maintaining that scapular function, so that levator scapula that will pull up that scapula itself, and those rhomboids that will retract the scapula. So if you have a lesion in that, you'll get that protracted winging of the scapula. And then the long thoracic nerve we all know about because it's that one that comes way down here, and that innervates serratus anterior. It has no sensory function whatsoever, and that's the one where you do the press off and you get that retracted winging of the scapula down. So if you're seeing winging of the scapula, think up close into the nerve roots itself, okay? Or out peripherally where they're being compressed. Both can be compressed, and we'll talk about those later. Brings up another point. When you're examining the upper extremity, especially the shoulder, have them take their shirt off if they're in a place where you can do it. You'll find a lot of things that you've missed if you have them take their shirt off. With girls, sports bra, just fine. All right, so that superior trunk, or that upper trunk, we're going to talk about the suprascapular nerve. This is a really, really important nerve, especially in sports medicine, because it innervates two very important rotator cuff muscles, the supraspinatus and the infraspinatus, okay? So this nerve can actually be a little bit tricky because it innervates both, but it can also be very useful because we can find entrapments, and I'll talk about those later. But we can tell it's where certain lesions are because it does innervate two muscles in succession. So we talk about supraspinatus, obviously that abduction movement, and infraspinatus, external rotation. And then the nerve that's subclavius, super, super important nerve. I examine the subclavius muscle, never. I never look at the subclavius muscle. Like, I can't tell you the last time I tested subclavius. Just know that there's no sensory function to it either. I threw it on there because it's out there. That lateral cord, this is one where I think a lot of people forget that the lateral cord of the brachial plexus also innervates the pec muscle. In the upper extremity evaluation, especially if somebody's having numbness or tingling, I very rarely see somebody come in and examine the pectoralis muscle to see if they can fire it. We're not looking for that bunched up test or with the press test, but if you do a press test and they cannot fire that pec muscle, or if you're trying to test adduction and they can't do it, start thinking in that lateral cord, because that's a pretty proximal muscle. And if they can't do that and they're having distal problems, think way up high in that lateral cord. okay? The musculocutaneous nerve we think about all the time because that's the one that innervates bicep, coracobrachialis, brachialis. It lets us flex that elbow. It gives us that strength that lets us do our curls. So we think about that all the time. What we don't think about is the sensory aspect of musculocutaneous nerve. It's called the musculocutaneous nerve because it has sensory innervation. And it kind of does that lateral forearm or that radial side of forearm here, okay? So the medial cord, that medial pectoral nerve is really the only one we think about much. Again, test the pec when you're looking at neurovascular problems in the upper extremity. Don't forget the pec. The posterior cord is really the longest one, and this is the one where we see the most in the upper extremity because it does so much for us, especially when you get to the axillary nerve. But that thoracodorsal nerve is legit. The latissimus dorsi is a muscle we don't think about a lot in the upper extremity, but it attaches up here in that proximal humerus, and it really is that ladder climbing muscle, right? So if somebody can take and do this movement right here, so they're bringing down or adducting and kind of internally rotating at the same time, but it's that what allows us to climb a ladder, and that's how you test it. I have them come right up here, resist here, and have them push down, and if they can do this movement here, the latissimus dorsi is intact. Okay, again, those nerve roots up high, C5, C6. But you can see when we're talking about the posterior cord, we get innervation all the way from C5 down to C8. So a lot of that crossover has happened there. The upper subscapularis, that subscap muscle, internal rotation, that belly press test, don't let them pull off of their belly, is super important. Again, the lower subscapular. This is where we start to get with teres major. Teres major is more in the adductor family. It's hard to isolate the teres major and test it specifically, but if you're having a lot of weakness in adduction, think about that subscapular. And then the axillary, that's the one that innervates the deltoid. That's the one that really gives us that abduction after 15 degrees. So the first 15 degrees is kind of supraspinatus. That initiates that abduction. And when that lever arm of the deltoid can really take over, we get the strength and abduction from the deltoid itself. These are the ones we think about after shoulder dislocations. The axillary nerve can be very easily damaged after shoulder dislocation. So make sure you're testing that sensory right out here over the lateral shoulder. Make sure you're testing that initiation of motion. It doesn't mean they're going to have 5 out of 5 strength right after they dislocated their shoulder, okay? Even with it still out, you can test to see if the abductor is intact. All they have to be able to do is initiate the movement. If they can initiate it, don't torture them and make them try to get it up here, because if their shoulder's out, especially anteriorly, they're not going to get there anyway. Then you can feel safe, do the reduction, and then again test it after you do the reduction. Teres minor is another one of those, kind of has a fun little test, the Hornblower's test. Anybody know what the Hornblower's test is? It's basically like you're holding a trumpet like this, and you try to externally, if you can't hold it up, if it falls, if it keeps falling into internal rotation, your teres minor is out. So if they can hold it up like this, they're externally rotating, and that's teres minor activity. It kind of isolates out the infraspinatus. It's not perfect, but it's a pretty fun test to say. So let's talk about the nerves themselves, because there's 3 really big nerves that come down all the way into the hand. And that ulnar nerve is one that you're probably going to see a lot of problems with. That's the C7 and C8 usually gets to T1. C7's kind of sometimes there, sometimes not. It comes off the medial cord of the brachial plexus. And so when you think about the sensory stuff for the ulnar nerve, I think we've all heard, these little fingers out here. So in blue, that's kind of the sensory distribution on the palmar or volar view, and then the dorsal view out there. I didn't type it all out, but you can see a picture. For the motor for the ulnar nerve is pretty important, because when you talk about that deep branch, it comes across and it does the hypothenar muscles, so those muscles kind of on the pinky side of the hand, those ones where you slam your hand on the desk, those hypothenar muscles. But it also gets in there and does the adductor muscles, okay? So it crosses over in the hand. When it comes through Guyon's canal, it crosses over and does the adductor muscles. So all the motions of the thumb, does everybody know what the motions of the thumb are? Okay, so if you don't, if you just hold your hand up, everybody hold your hand up. I can see you, it's not that dark out there. All right, so if you close your thumb, that's adduction. If you open your thumb, that's abduction. If you bend your thumb, that's flexion. If you open your thumb up, that's extension. And then if you touch your pinky, that's opposition. All right? So when you're talking about the motions of the thumb, those are the 5 important motions. That's what separates us from most animals, okay? We have an opposable thumb, opposition of the thumb. That's what allows us to do 90% of the things we do as human. also our brain power for like 50% of people, okay? It also innervates the intrinsic muscles of the hands. So those lumbricals number 3 and 4, those interosseous muscles, kind of allows us to do the opening and closing of our fingers, okay? So ulnar nerve is very important. Pay attention to the ulnar nerve. These are the ones where, you know, they say, I wake up in the morning and my pinky's completely numb. We'll talk about ulnar nerve entrapments later. Median nerve, mostly C6 through C8, sometimes T1, sometimes C5. The median nerve catches everything. It comes off the medial and lateral cords, and because of that, it catches a lot of innervation from different cervical nerve roots. Again, that sensory innervation in those median nerves you see here in yellow, mostly in the palmar side or the volar side of the hand, although it does wrap around the fingertips of the thumb and the first 3.5 digits. So pay attention there. If they're saying the tip of my middle finger is numb, or, you know, the palm of my hand is numb, that's kind of more in the median nerve. The thenar muscles here are really important, especially that recurrent branch. You'll see the recurrent branch gets damaged a lot, or I say a lot. Hand surgeons really pay attention to the recurrent motor branch of the median nerve because it can get clipped. It's called the $1 million nerve. So if somebody has a carpal tunnel release and they clip that branch, they're gonna get $1 million because they're supposed to look for it, okay? The median nerve is really what gives us that opposition, that flexion, and even the abduction. So the median nerve is really the big mover of the thumb. Just remember that adduction of the thumb comes from the ulnar nerve, okay? And then all those flexors, right? So pronator teres allows you to pronate, and then palmaris longus, flexor carpi radialis, all those flexors that allows you to flex the wrist, pronate the wrist, and then move the thumb. That's the median nerve. AIN, or anterior interosseous nerve, is a large motor branch of the median nerve. It's a really important nerve. It comes with a lot of syndromes. What you really need to know is that those flexors and that pronator quadratus are there. It can get entrapped. The sensory part of it is really a deep sensory. You can't really test on the skin. It actually innervates the capsule of the wrist. But it's an important nerve to think about, especially in that flexion and pronation. If you have an AIN syndrome or an entrapment, you have trouble with those. Radial nerve, this is the extensor nerve. If you think of anything else, the radial nerve does extension of the elbow, it does extension of the wrist, it does extension of the fingers. You should think extension, extension, extension. So if you see radial nerve on the test, or they say they have a lack of extension, think the radial nerve, okay? All these are extensors here. And then the sensory is probably the smaller on the palmar or volar side, but then on the extensor surface, because it's an extensor nerve, it does a lot of the dorsal side of the hand, okay? Posterior interosseous nerve is a large branch, a very, very important branch off the radial nerve. Posterior interosseous nerve syndrome, we'll talk about later also, is pretty common. I think it's another one of those things that sees you more than you see it. But it can affect a lot of things. That PIN is the supinator, so it allows you to do this, and all the extensors. So really, most of the extensors are coming out of that PIN, especially in the thumb extension and wrist extension and supination. So it allows you to kind of do this, all right? Notice that everything I'm talking about kind of groups together. Right, so when you're losing big groups of extensor muscles, think big radial nerve lesion. If you're losing small bits of extension, like I can't extend my wrist, but I can extend my fingers, think specific entrapments down distally. So speaking about entrapments, nerve entrapments are actually pretty common. The human body is designed in a really, really cool way, right? I mean, if you think about it, what are the odds that this, I mean, I know I'm quite the specimen, but this came together the way it did, right? So we have nerves that run through tunnels, and we have pulleys that allow us to bend our fingers without the tendons flexing and bowing out. And we have all of these really cool, intricate things that happen in the body, but we have to be able to bend our elbow. We have to be able to put our hand above our head to do the things we need to do. So when we come across weird things like this, like an elbow that can bend way past 90 degrees, the possibility of entrapments happens. And when nerves get entrapped, they start to get irritated because that endomysium and myomysium and endomysium and myelin sheath, that surround the nerves that allow conductivity to happen faster, when they get compressed, they lose blood supply. And when they lose blood supply, they start to atrophy. And when they atrophy, they can completely go away. And so if you have somebody that's coming and telling you, I have numbness here, or I have tingling here, and you get to that point where you can address it at the early stages of compression and stop it from happening, you can stop that progression through and hopefully prevent more permanent damage, all right? I get a lot of patients that come to me and said, I've had this pain or numbness in my hand and they have carpal tunnel syndrome. And why are you just coming to me now? I went to my doctor 5 years ago and he said it's just carpal tunnel syndrome, there's nothing we can do about it. Well, now there's not, because it's permanent, okay? But if you catch these things early and you're paying attention to them and you're focused in and you're thinking, man, maybe this is really a focal entrapment of a nerve, I need to have this looked at a little bit more closely to see if we can remedy that, you can stop this progression from just normal nerve to little neuropraxia all the way down to complete destruction of the nerve. So if somebody's telling you they have sensory symptoms, numbness, tingling, but they don't have weakness, especially in a mixed nerve like the musculocutaneous nerve, so I'm getting kind of tingling over my arm, but they still have all of that strength in the flexion of the elbow, you're early on here. You're still in just the sensory phase. As you get into that motor phase and they get weakness, you need to be really pushing to get that person looked at a little closer. So the median nerve gets entrapped everywhere. It's by far the most common one, always in the carpal tunnel, carpal tunnel, carpal tunnel. I read somewhere like 12 million people in the United States get diagnosed with carpal tunnel syndrome a year. It seems like a lot. I feel like that's probably a high number. But it is very common, and you can see here that there's different places where it can get entrapped. The most common, obviously, carpal tunnel. There's this thing called pronator syndrome. That median nerve has to run near the pronator teres muscle. Sometimes it goes over, sometimes it goes under, sometimes it goes straight through, but that is a place for compression there. And then this arcade of Struthers, which is proximal to the elbow, it's up at the distal humerus. That arcade of Struthers happens. You'll see this every so often. There's this arch of a fascia here where that flexor digitorum superficialis kind of starts to fan out, and it can get entrapped there. But we'll talk about the more common ones. So carpal tunnel syndrome, this is the one where you have the secretary, sits at a computer all day, hand goes numb, gets pain in the thenar eminence, usually radiates proximally late in disease. I have had patients come to me complaining of shoulder pain. Their shoulder was completely normal. You start to examine them more distally, and you find out they have a positive Canals, which is that tapping, right? Or a positive phalens, which is that reverse prayer kind of thing. And when they have that positivity, their shoulder starts to hurt. So never forget that nerves run both directions, right? Nerves run from proximal to distal because they have to innervate things, but they also run from distal to proximal because they have to receive information. And that pain sensation can run proximally. So you can have a distal lesion that's causing that referred pain proximally. That's a referred pain pattern, okay? You have to be careful. Again, this may become permanent. This is that transverse carpal ligament. It's a very tense, very dense, fibrous ligament that creates the carpal tunnel, and that median nerve sits right underneath it. And so if that median nerve swells up, or if it gets entrapped or gets pinched, you get this carpal tunnel syndrome. Usually we treat it conservatively because we can get that thing to stop swelling, night splints, things like that. But when conservative treatment fails, we usually go to surgery. We usually do a carpal tunnel release, okay? Full disclosure, I'm not a surgeon. I'm a primary care doctor. I have family medicine training, and I did a sports medicine fellowship, so I don't do surgery. Pronator teres syndrome. I know this is a busy slide. I apologize for it. It's kind of the best picture I could find. But if you look here, this pronator teres muscle comes right here. And if you look at this nerve right here that's coming through it and right over the top of it, that's the median nerve. So you can see how it's a possibility to get entrapped right there. This is one of those that I think has probably seen you way more than you've seen it. This is one of those like vague lateral elbow pain. It kind of hurts out here when they do stuff. You see this a lot in your young, kind of jacked guys where they lift a lot of weights and their forearms are massive, and that hypertrophy of the muscle can actually make the compression worse. So if you've ruled out, lateral epicondylitis, and you've ruled out all those other really common things in elbows, think about that nerve, that pronator teres syndrome, that median nerve kind of getting compressed, and it can really radiate down into that thenar eminence. They can get this kind of vague pain that, sometimes it's my elbow, sometimes it's in my hand. Like I feel a little clumsy sometimes, like my thumb isn't working the way it's supposed to. Really think about that median nerve and pronator teres syndrome. Maybe? There we go. Okay, so I'm gonna apologize for putting this picture on here because I found out last night, bad, don't do that. I didn't know what it meant until last night. I'm not gonna say what it means okay to me. AIN syndrome, pretty rare, but it can happen, okay? Remember, the AIN is a distinctly motor nerve. It doesn't have any sensory component to it. So really the way you test this is, can you put fingertip to fingertip? So index finger to thumb, fingertip to fingertip, and make that circle. What you do with these 3 fingers, I don't care. If you can do this, your AIN is intact, okay? Now, you may have varying degrees of strength, and that may be a muscle problem, so you have to pay attention to that. But if they can do this movement, your AIN is intact, okay? The ulnar nerve, this one we see a ton. That cubital tunnel, this lovely little thing, one of those wonders of engineering that I'm not sure how it works as well as it does most of the time. This ulnar nerve runs right under that medial epicondyle, right through that cubital tunnel. And usually what we'll see is when people get really hyperflexed in their elbow, one of 2 things happens. It either puts that nerve on a stretch, or that nerve subluxes out of the cubital tunnel, and they'll feel a pop or a snap, and then they'll get symptoms, okay? Again, Tenel's, that tapping over it, mine is super positive all the time, so I'm not gonna do it for real. But tapping over that nerve will recreate those symptoms. This is one of those things we see a lot in overhead athletes, baseball players, volleyball players, super tall volleyball players, your outside hitters, those girls that come up there and they really are cranking on that ball. They get way out here. It's exactly the same motion as a baseball picture, except they don't get the wind up. All they get is a step and a swing, right? And so you'll see it a lot in them. I try to treat these with night splints. I try to keep them out like so. Try to keep them out to where they're not getting, because everybody falls asleep and they want to do this, right? Head behind their head, and they're like, I'm sleeping, but then they wake up and it pain, and then they get weak. But it's super common, okay? Super, super common, that cubital tunnel syndrome, which is the next slide, because I knew that. All right. In severe cases, they will get weakness of those intrinsic muscles of the hand. They may even get some hypothenar and thenar atrophy. This is super late in the game. If you're that far down the road in this game, you're behind. You're way, way behind. We try to address these when they start to get the sensory components, okay? I don't know what just happened. Okay, Guyon's canal compression. A little less common, but can be super common in certain activities. I see this more in rock climbing than I see in much of anything else. People who have to use their hand. It kind of goes along with another syndrome I'll talk about, but it's ulnar nerve. It's an ulnar nerve compression, but it's a distal ulnar nerve compression. So Guyon's canal is at the same level as the transverse carpal ligament. It doesn't run through the carpal tunnel. It runs through its own tunnel. But it runs down here, and you'll see this, you'll get that similar paresthesia in the fingers because it's still distal to the compression, but you usually have the sparing of those flexors of the finger. You usually are able to flex the finger because that flexor digitorum is innervated far more proximally. So you can flex the fingers, but you still get that numbness and paresthesias. You can still get that atrophy though, so pay attention to it. If they have those paresthesias, you need to find out where along that ulnar nerve you're getting compressed. Okay? Again, Guyon's canal. Hypothenar hammer syndrome, it's always on sports medicine tests. It's probably not on your test, so you probably don't have to pay attention to it. But a lot of times rock climbers will bang their spikes with their hands instead of using a hammer. And when they do that, they actually damage that ulnar artery that runs along with the ulnar nerve, and they'll get chronic clots in there. That's one of the things you have to kind of tease out. So again, history. If they hit something a lot and they're getting paresthesias, it may not be a nerve injury. It may be an arterial injury that needs to be evaluated a little bit more. Fromet sign is the big one that we look for ulnar nerve damage. This one gets confused a lot. I have athletic trainers confused. I have sports medicine fellows confused. The only people I know that know it cold are the hand surgeons. So remember, the ulnar nerve is the adductor, right? So you adduct the thumb. So if you take a piece of paper and you hold it and you have them adduct the thumb, so this is adduction, and you try to pull it away, and if that thumb flexes to hold that paper, if it flexes, so now we're doing, instead of the ulnar nerve, we're using our median nerve to hold that paper, that's a positive Fromet sign. That's a weakness of the ulnar nerve. If they can hold that thumb flat, and not let you pull that paper out, that's a negative test. That means the ulnar nerve is intact to the adductors of the thumb. That one gets confused a lot, so kind of put that one in your bank there. It's confusing. You're like on this slide, you're like, is this one being tested or is this one being tested? Either one. If this is a test, it's a negative test, right? Because they're not flexing the thumb. If this side's getting tested, this is a positive test because they're having to flex. Instead of having adduction, they're flexing the thumb, okay? Radial nerve entrapments happen not super commonly. We will talk about the PIN a little bit. The one that happens that I think is fun to talk about is the Saturday night palsy. You should not be seeing this much in your middle school and high school athletes. You might accidentally see this a fair amount in your college athletes. This is the one where they get so drunk they fall asleep, and either they have their hand up over their head like this, or they fall asleep over the back of the chair, and it compresses that radial nerve right here at that spiral groove of the radius, or of the humerus, sorry. So you see how that radial nerve runs right in that spiral groove, and it's like, it's also, you can get it when they use crutches wrong, like if they're really leaning on their crutches on their humerus instead of using their hands, they're really hanging up in their axilla. You can see this quite a bit. And what you see here is wrist drop. They can't extend the wrist. Remember, radial nerve is extensors, right? So they get wrist drop. So they can't extend. And they might be able to fire it, but they really can't do it very well. I will tell you as athletic trainers, this is where you really have to pay attention to those crutches. Make sure they're using crutches. Because you can get a pretty good palsy, and you can get a pretty permanent palsy if they don't pay attention and fix it. PIN syndrome, again, that compression, that vague pain, again, over the lateral epicondyle. Those extensors become weak. Now again, you get that wrist drop. So other nerve palsies, this is a picture of a sunrise in the deserts of Mexico. There's some deer over there. I fed them. They were happy. Those made it. Those were the lucky ones. All right, so weakness of the serratus anterior with this long thoracic nerve. Again, C5 through C7, a pretty big expanse here. If you notice here, this long thoracic nerve, it's called the long thoracic nerve because it is a very long nerve that runs over the thorax, and it innervates each muscle belly individually of the serratus anterior. So if you have a really pronounced wing of the scapula, like in this picture, or like some of these kids, you have them do a wall push-up and that thing just flies right off their back, you know, the lesion's probably up here proximally, okay? If you have like a more minor one, you can get lesions down distally that still innervate these upper serratus muscles, but don't innervate the lower serratus muscles. So you can try to tease that out a little bit, but in general, if they have a long thoracic nerve palsy, it's gonna be pretty pronounced winging, okay? Most of the time it's idiopathic. It can be traumatic. Receiver that goes up to catch a ball takes a shot right to the thorax, to the chest. You can stun that nerve just like you do a dead leg or anything else. You can stun that thing and see a pretty pronounced temporary palsy, okay? Axillary nerve, we see this here with compression after surgery. I've seen damage after surgery. It can get trapped in this quadrangular space. Don't panic. Don't have to remember what the quadrangular space is, although you probably should know it. Again, compression here. A lot of times you'll get vague kind of posterior shoulder pain because the axillary nerve does innervate part of the posterior capsule of the shoulder. But again, you can get that weakness in abduction. Suprascapular nerve, this is the one where I think it helps us to tease out a little bit because it innervates the both nerves here, the supraspinatus and infraspinatus. If you get weakness of both supraspinatus and infraspinatus, the lesion has to be before the suprascapular notch. All right, so there's a notch in the scapula where it runs through along with the artery, and it can get entrapped here. So if both the supraspinatus and infraspinatus are weak, it has to be proximal to that, and it's usually in the suprascapular notch. If only the infraspinatus is weak, it usually is in the spinal glenoid notch, which is right here. And this is usually in people that have big labral tears that develop labral cysts that push out posteriorly, and that cyst will compress the nerve right there, and they have weakness in this external rotation. They can abduct, but they can't externally rotate. You usually get some weird pain radiation here. That's usually a referred pain. So plexopathies, this is in Utah. It's very pretty. You guys know burners and stingers. I'm not going to belabor burners and stingers. I will tell you this, if you ever have somebody that has bilateral burners or stingers at the same time, or if they have more than 3 on the same side that are pretty similar in origin, they need to get worked up. They need x-rays, they need an MRI. There's usually something congenital happening there, okay? Don't ignore the backpack palsy. These kids that walk around with 50-pound backpacks can really put a lot of traction on that upper trunk of the brachial plexus. Neuralgic amyotrophy, this is Parsonage-Turner syndrome. This is a very late picture. You notice here the atrophy of the deltoid, of the supraspinatus, of the infraspinatus, and the winging of the scapula all at one time. This is a inflammatory neuritis of the entire brachial plexus, all right? This is hard to figure out sometimes until very late. But if somebody comes to you and is like, my entire arm hurts, my entire shoulder hurts, something is wrong, be in the back of your mind, think this could be Parsonage-Turner. They usually have to get EMGs, but we can't get them for 6 weeks, otherwise they're normal. Usually self-limited, but I have one patient that still hasn't resolved after 5 years. Neoplastic, never forget cancer can do anything. Sometimes you can get these upper lung cancers that press on the inferior plexus. If you have somebody that comes to you and they're having shoulder pain or radiation down their arm, and one pupil is bigger than the other, and they have ptosis or the eyelid is drooping, they need to go to a doctor that day, probably the ER. Because if they're having eye symptoms with shoulder pain, you have to worry about this Pancoast tumor. Not common, but just something to think about. Nerve root avulsions, these are kind of everybody's nightmare. If you avulse the nerve root off the cord itself, that is unfixable, okay? And the problem is a lot of times it takes a little while for you to figure it out, because when you acutely avulse the nerve root, that nerve still thinks it's alive. And it may take up to 2 to 3 weeks to get the full picture of what's going on. So if you have somebody with a neck injury that you're like, I don't know what's going on, don't be afraid to get an MRI. They're too cheap these days. You can stretch the nerve, you can actually snap the nerve distal. If you do this, this is way better than this. This is potentially fixable, okay? But just pay attention, just know that that can be in your differential. Thoracic outlet, I am not going to talk much about thoracic outlet syndrome. I could talk for 6 hours on thoracic outlet syndrome, all your eyes would cross, because you would be just as confused as I would be giving you a talk about thoracic outlet syndrome. Just know that when you get up into this position here, if something causes neurologic symptoms, you should be thinking about thoracic outlet. I literally went to a 2-hour lecture on this thing, and I came out like, oh crap. Things that can kind of mimic neurologic problems that are not true entrapments or nerve problems, these are the things that you're like, something's just not making sense. There's more out there than what's meeting the eye. Lupus, 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 lupus. It's way more common than we think it is. Lyme disease in Texas is becoming a really big thing. We're starting to find more and more. Never underestimate the diabetic. HIV and AIDS is less common now because of PrEP, but pay attention to that. Syphilis can mimic anything, literally anything. So if somebody comes to you and say, I have numbness and a rash on the palms of their hands, they need to go see somebody. There are some odd vitamin and mineral deficiencies like B12 and folate deficiencies, and then the myopathies. The other one that I don't have on this that I had on my other version is multiple sclerosis. So if something is coming out and you're just like, this doesn't make any sense. The myotomes don't make sense. The dermatomes don't make any sense. Nothing lines up. Think brain. That's coming out of the brain. And so you have to pay attention to that. And then the congenital issues. This is a picture of a syrinx. A syrinx is basically a defect in the spinal cord. I'm gonna get over here so you guys can see it. But the spinal cord on this image should be dark all the way through like it is up here. So as you come down, you see right here it gets bright white, and it has dark on either side. This is spinal fluid inside the cord. That's a syrinx. And those can cause really, really weird symptoms. So if something's not adding up, don't be afraid to ask for help. Things that are bad, things that I don't like to see, clonus. So clonus is that thing when you take the hand and you extend it against force and it fights back against you. So you pop it and it pops back against you. 1 or 2 beats of clonus, if it's bilateral and symmetrical, is fine, okay? If you have sustained 4 or 5 beat clonus and it's unilateral, they need to go see somebody and get imaging. That's a problem, okay? Hoffman's sign is that really weird one that nobody really knows how to do, but you have them relax their hand and you kind of snap on the fingernail of the middle finger and you kind of force it into flexion, and what'll happen is their thumb will flex towards their index finger. So that's a sign of hyperreflexia. Hyperreflexia usually means some sort of central lesion or compression. And then any asymmetrical hyperreflexia. So if you do a biceps on this side and it jerks, and you do one on here and it's kind of, yeah, I usually have them looked at with imaging, okay? Any questions? Only if you want to make this thing longer. That's a picture of my nephew trying to do his best Uncle Jason belly impression. He's so cute. All right, those are my references. I appreciate your time. Thank you very much.